Good morning. Today is August 12th, 2020, and this is our 13th in a series of calls for Medicaid behavioral health providers and stakeholders. These calls seek to provide verbal updates on our response to the COVID-19 state of emergency and our associated guidance. We thank you for being here on the call today. I can see that we have 171 participants as of right now, with more coming in. My name is Dr. Alyssa Ward. I am the Behavioral Health Clinical Director at Virginia's Department of Medical Assistance Services. And we appreciate your participation in the WebEx event. Want to remind you that due to the large number of participants, everyone will be muted today except for our panelists. We will be answering a limited number of questions about service flexibilities or Medicaid policies in the Q&A function of this event today. We do want to remind you that our hosts and panelists will be focusing on the facilitation of the meeting, so we will limit our responses until the end of our presentation, and then we will look through the Q&A and determine if there are questions that we are able to respond to live on the call today through that chat function. We always value your feedback and questions. If we don't get to those questions today, you always have the opportunity to write to us through our two email accounts. Those are enhancedbh, as in enhanced behavioral health, at dmas.virginia.gov for mental health policy questions, and SUD, that is substance use disorder, SUD at dmas.virginia.gov for arts-related policy questions. Please reserve that Q&A function for both questions about technical issues that you may be experiencing, or to cue any of us panelists who may need to speak up or adjust our microphones. We do encourage participation over the computer, as we have slides, though you are always able to listen in over the phone. We know that there have been concerns that we have shared as well about state level capacity to do closed captioning for these types of events. DMAS is very close to procurement of a functionality on WebEx that will allow for automatic closed captioning, and we anticipate that will go live very soon. For the time being, the recordings are available on the website along with the slide decks. I'm joined as usual today by Ashley Harrell, our senior program advisor for the arts program. And additionally, today I'm joined by April St. John, who is our acting behavioral health manager in our division. This is our agenda for today. I'm going to start off with our regular kind of global overview, and then Ashley Harrell will take it away with some additional updates and resources. April St. John will cover a few frequently asked questions, and then we'll see what time we have left to address any questions from the Q&A function. We are now 5 months into the state of emergency associated with the pandemic, and we here at DMAS remain vigilant to our collaboration with VDH and in watching all of the associated data and cross-agency response. As the pandemic evolves, we stand prepared to adjust any of the flexibilities and guidance that we continue to offer through these calls and our memos to reflect appropriate mitigations measures important for protecting the health and safety of our members and, of course, you as providers and stakeholders. Want to remind you that, as I noted before, these calls are recorded and they are uploaded to YouTube, and then they are posted via link onto our DMAS COVID-19 page of the website. That page is pictured right now on your screen so that you can identify when you go to the COVID-19 page. You do need to scroll down a bit to get to the behavioral health information section. Next slide. We also update our frequently asked questions into a document that is loaded onto that page and is indicated by the arrow here. We want to make a broad note today. This is not directly related to all behavioral health providers, but there was a release of a memo that was blasted last night and I believe should have been circulated through some of you today. This is a memo on continued flexibilities related to the developmental disabilities waiver and Commonwealth Coordinated Care Plus waiver. Sorry, the slide went backward. The flexibilities in this new memo, again, are limited to those in the home and community-based services waivers, and basically just highlights that any flexibilities listed in previous Medicaid memos are still in effect until the current state of emergency expires. Next slide. The memo that was just posted provides updates on the planned expiration dates. I'm sorry, Ashley, can you go back one slide? Our apologies. WebEx can be very sticky with the slides, and at times they are beyond the control of the host who is moving them. It can take a moment for them to load backward. I see that Ashley is going to reload the slides on the deck. So let's move to the next slide, if possible, Ashley. Slide 6. So essentially, this new memo that came out provides updates on the planned expiration dates of the Home and Community-Based Services 1915C waiver flexibilities. Essentially, DMAS is granting the extension of those flexibilities for the purposes of provider staffing, access to care, and minimizing viral spread through community contact. So all of the flexibilities listed in this new Medicaid memo are extended until January 26th, 2021, the approved end date of the Commonwealth's Federal Appendix K authority. So again, we're aware these are not directly related to all behavioral health providers, but in the interest of getting information out and knowing that we have many providers who do provide services within these waivers on these calls, we just wanted to highlight the content of the memo, just letting you know that some of the flexibilities that are listed in that memo, including allowance for providers and MCOs, the option to conduct evaluations, assessment, and person-centered planning meetings telephonically or through video conferencing in lieu of face-to-face meeting requirements, and allowing for telephonic and video conferencing method of service delivery for case management, monthly monitoring, in-home support services, community engagement, community coaching, and therapeutic consultation. Next slide. This memo also provides information about the allowance of group day services within residential settings as set forth in the May 15th memo. Beginning August 15th, requests for telehealth service delivery for plans authorized after March 12th, 2020 may be submitted for consideration. And it allows legally responsible individuals to provide personal care, personal assistance services for reimbursement. There is additional information on these waivers on the DBHDS website, and that memo is available on the DMAS website and was blasted out yesterday or last night, my understanding. We mentioned this in our call last week, but just to reiterate, there was a letter published on July 17th from our partners at DBHDS providing some information on reopening recommendations across clinic-based and non-clinic-based services, and a particular recommendation document around therapeutic day treatment. We thought these would continue to be of interest to you. We will continue to work with DBHDS to update these recommendations as the pandemic evolves. And just wanted to note that at DMAS, we have been speaking with the associations and with providers about the functioning of TDT during the pandemic, and are quite aware of system anxiety about schools moving to virtual or hybrid schedules and the impact on the delivery of TDT services. And we are seeking to develop some recommendations around those issues, and are working as quickly as we can on that effort. Next slide. We also mentioned last week, 2 weeks ago in our last call, that there have been some additional federal coronavirus relief funds that have flowed down through the state and have been distributed to local governments. There were some questions in the call last week about a link to this formal memo regarding these relief dollars, and we provided that in the chat last week. Also, if you Google any of the words on this screen, you will likely find that announcement and a link to it. Next slide. We also want to make a repeated note about emergency payments for Medicaid providers, as Medicaid providers have the opportunity to receive coronavirus relief funds to support them. Through the federal U.S. Department of Health and Human Services, there are $15 billion available for providers who participate in Medicaid and the Children's Health Insurance Program and have not received a payment from the Provider Relief Fund general allocation. The deadline for the applications for these funds has been extended again to August 28th. So we do encourage providers to apply, even if you're uncertain whether you're eligible. All providers receiving these payments will be required to comply with reporting requirements as described in the terms of conditions. And there is a report on the HHS website that detailed instructions regarding those reports are going to be released next week on August 17th. So the links are available here. Next slide. Another reminder that many folks have come into the telehealth workforce here in Virginia, many LMHPs, through amended Executive Order 57, which allowed for temporary licenses for licensed mental health providers in Virginia. These temporary licenses are set to expire in less than a month in September, so we do want to encourage any of you who are employing anyone with these temporary licenses, or if any of you are holding them, to go ahead and apply for a full Virginia license should you be eligible, or make preparations to transition patients to Virginia licensed practitioners by that deadline. We have not seen an extension on this yet. Next slide. I'm now going to turn our conversation over to Ashley Harrell to go over some additional global updates and resources.
Thank you, Dr. Ward. Good morning, everyone. I will now cover behavioral service utilization during the state of emergency. The overall trends for behavioral health services have been analyzed by applying an IBNR methodology, or incurred but not reported. IBNR is a type of reserve account used in the insurance industry as the provision for claims or events that have transpired but have not yet been reported or submitted to an insurance company. The traditional IBNR reserving approach uses claim lag triangle information to estimate completion factors or payment patterns to then estimate ultimate incurred claims and the estimated outstanding liability. DMAS analyzed primary care services compared to behavioral health services. You see here that the primary care service expenditures significantly decreased during COVID-19, 31% in April and 39% in May. Behavioral health service expenditures remained largely stable through COVID-19, only an 11% decrease in April and 2% decrease in May. Also of significance, behavioral health providers by far are the main users of telemedicine. 23 of the top 25 diagnosis codes associated with the telehealth visit is behavioral health. This data is aligned with what we have nationally, where the utilization of behavioral health services has not decreased as significant as some of the medical services. This slide shows you the community mental health rehabilitation services by managed care utilization or expenditures, utilizing actual claims and the IBNR methodology. The average incurred is the orange line, and this shows that these expenditures have been constant through COVID-19. This slide shows you the addiction and recovery treatment services, or the ARTS benefit, through managed care expenditures, utilizing, again, both actual claims and IBNR methodology. You can see here that substance use disorder services have shown an increase in service utilization and expenditures during COVID-19. The top 10 diagnoses through telehealth were largely behavioral health with one medical diagnosis. The top 10 are listed here on your left, including ADHD, opioid diagnosis, depressive disorder or mood disorders, autism, anxiety, PTSD, psychosis, schizoaffective, adjustment disorder, hypertension, and ODD. You also see here that the top utilizing behavioral health providers appear to be community service boards. In regards to behavioral health service, the largest jump in the use of telehealth for behavioral health providers was with psychotherapy, therapeutic day treatment, intensive in-home services, opioid counseling, and psychosocial rehab. Overall, behavioral health service utilization has remained comparatively stable, likely due to telehealth allowances. This is consistent with other states and national trends. There are areas of variability due to the nature or context of some services, such as group service limitations, school closures, for example. We are not seeing a surge of new members seeking behavioral health services in the current window of assessment, though we anticipate those trends as the state of emergency and social distancing continues. Ultimately, the data is showing that providers were able to adapt and use a combination of telehealth and face-to-face service delivery models to continue to provide services. In fact, many advocates and lobbyists continue to ask Congress to mandate that all insurers expand coverage for telebehavioral health, require reimbursement parity, allow providers to practice across state lines, eliminate geographic restrictions, and cover multiple modalities, including the telephone. During the coronavirus pandemic, the Centers for Medicare and Medicaid Services, or CMS, has taken unprecedented action to expand telehealth for Medicare members. Since people were advised to stay at home to reduce the risk of exposure to COVID-19, there was an urgency to increase access to telehealth services to help people who need routine care and allow beneficiaries to remain in their homes. Early CMS data have shown telehealth to be an effective way for people to access healthcare safely during the COVID-19 pandemic, whether it's getting a prescription filled, managing chronic conditions, or obtaining mental health counseling. Before the public health emergency, approximately 13,000 beneficiaries for fee-for-service Medicare received telemedicine in a week. In the last week of April, nearly 1.7 million beneficiaries received telehealth services. In total, over 9 million beneficiaries have received a telehealth service during the public health emergency, and this is mid-March through mid-June. There are also no significant differences by race or ethnicity among beneficiaries who receive telemedicine. 25% among Asians, 29% among Blacks, 27% among Hispanics, 28% among whites, and 26% among others. In light of our new experience with telehealth during this pandemic, CMS is reviewing the temporary changes made and assessing which of these flexibilities should be made permanent or through regulatory action. As part of CMS's review, they are looking at the impact of these changes that have had on access to care, health outcomes, Medicare spending, and the impact on the healthcare delivery system itself. I will now transition to resources that we have covered before with a couple new for behavioral health providers. So we are proud to support Virginia's new application to help stop COVID-19. We ask you to join the movement and download COVIDwise for free in the App Store and on Google Play. You can also visit covidwise.org. COVIDwise uses Bluetooth Low Energy Technology, or BLE, to quickly notify users who have likely been exposed so you can reduce the risk of infection for your friends and family and help Virginia stop the spread. DMAS's Support Act grant just posted a request for applications for subawards to expand addiction and recovery treatment provider capacity for Virginia Medicaid members. Eligible applicants include current Medicaid providers, providers who plan to become a Medicaid provider, or organizations that provide training and technical assistance to substance use disorder treatment and recovery providers. Examples of potentially funded activities could include staff time, training, and other items necessary to become a preferred office-based opioid treatment provider, staff time associated with coordinating hepatitis C treatment, technical assistance per hour, evidence-based substance use disorder training. This includes the American Society of Addiction Medicine, CCAR, which is the training for peer recovery support specialists in the emergency department, trauma-informed care, HIV or Hep C. These could also include costs related to performing targeted community-focused needs assessments to understand specific challenges and barriers facing individuals attempting to access Medicaid paid substance use disorder treatment. The funding could also include address telemedicine infrastructure, as well as office supplies, equipment, and furniture. So we have provided the link here. I will actually put this in the chat function, or the Q&A function, so that you have it, and we encourage you to follow the link to see the requirements for this funding and submit your application. Next, we have wanted to provide you with information on PracticeWise. PracticeWise offers innovative tools and services to help clinicians and organizations improve the quality of healthcare for children and adolescents through the use of evidence-based practices. PracticeWise now has a series of free webinars that are available for replay on demand. And that link is provided here, and we encourage you to visit that to see the entire menu of events and to access all the videos and other resources that PracticeWise has to offer. Next, we have the Support Act grant team. They continue to offer technical assistance and training webinars designed to increase substance use disorder knowledge and to provide support to anyone who serves Medicaid members with a substance use disorder. The overall goal of the webinars, as well as other grant activities, is to increase addiction and recovery workforce capacity while also creating a culture of understanding, empathy, and support for individuals with substance use disorder in various workforce settings. DMAS has facilitated over 80 web-based sessions since April, and we have reached close to 3,800 individuals. I encourage you to go to the ARTS website at this link you see on your screen, and you can go to the middle of the web page and see the topics that Paul Brassler, who's our addiction behavioral health consultant, he's our LCSW on our grant team, as well as Dr. Mishka Turplin, what they will be presenting on during the month of August, as well as the slide decks from previous sessions. This resource is from the National Clinician Consultation Center through University of San Francisco in California. And they have a team of expert physicians, nurses, and clinical pharmacists to support healthcare providers in delivering high quality care to patients of all ages. This is free and confidential and for all experience levels. And I know that Dr. Turpin is one of the clinicians that works with this consultation center. Next, we are working in collaboration with our partners at Virginia Department of Health. Lisa Wooten and Jean Hoyt are helping us to provide free buprenorphine waiver trainings to our physicians, nurse practitioners, and physician assistants that are interested in seeking their buprenorphine waiver that would allow them to prescribe buprenorphine products for the treatment of opiate use disorder. This online session will deliver the required live portion of the total training hours. And then following the training, participants who have successfully completed their course may apply to SAMHSA to obtain their waiver. Again, here's the date, August 26th from 9 to 1, and the link. And once you register, you will receive an email confirmation, and that will include the Zoom link and a reminder email prior to the training. We also have Naloxone trainings and resources, and this is very important that anyone that is prescribed an opioid or, are taking medications for the treatment of opiate use disorder have access to Naloxone. Here's a resource through DBHDS, a Revive program. They have an online training, as well as the website for getnaloxonenow.org. And you can register and enter your zip code to access the free online training. There's also Naloxone through the Chris Atwood Foundation that you can get via mail. And this is for Virginia residents only, and it is the IM administration. And please know that Medicaid provides Naloxone. There's no cost and there's no prior authorization requirement. Medicaid members who are limited English proficient or deaf or hard of hearing are entitled to language access services. This includes the availability of language assistance services as well as sign language throughout the entire Medicaid process, including assessing information about the Medicaid program, completion of a Medicaid application, obtaining medical services, as well as the appeals process. DMAS is committed to ensure providers are responsible for providing free language access to its patient population with competent interpreters and translators. Thus, DMAS is creating a language and disability access plan to include language guidance for DMAS providers. This guidance will cover legal history for language access, who this applies to, who is limited English proficient individual, how does a member determine the extent of its obligation to provide language access services, how to select language assistance services, and training resources, and much more. So we will share this as soon as it is live, that we'll be issuing a DMAS memorandum for posting. This is brand new in collaboration with the University of Virginia, School of Medicine, and the University of California in San Francisco, National Clinician Consultation Center. We have organized a webinar to discuss hepatitis C treatment. During the event, we will address the importance of hepatitis C treatment and provide tools to assist with treatment. We encourage hepatitis C treatment providers and providers interested in offering hepatitis C treatment to attend this event. And you see here the following topics are covered. And this is especially important with individuals with a behavioral health or substance use disorder, as they are at higher risk of obtaining or getting hepatitis C. And we have the registration for the event located here. Also new, this has come from requests from our stakeholders. We are facilitating a DMAS provider appeals overview. Please join us on September 2nd at 11 o'clock to hear Mr. Joshua Leaf, DMAS's provider and medical cases manager, to provide this overview for behavioral health providers. And now I will pass it over to my colleague, April St. John.
Thank you, Ashley, and good morning, everyone. We will now take a look at just two of our more recent frequently asked questions. Next slide. Our first question is in regards to billing for counseling services and a preferred OBOT. The question is, in providing individual and group counseling, can billing codes 90832, which is 30 minutes of individual counseling, or 90853, which is group counseling, be used instead of the H codes for individual and group counseling? The answer is the OBOT specific counseling codes H0004 and H0005 can only be billed by preferred OBOTs and OTPs for members with a primary diagnosis of opioid use disorder. The outpatient counseling codes can be used if a member receiving services at your location does not have a primary diagnosis of opioid use disorder. Next slide. Our final question is an inquiry as to the status of the behavioral health enhancement proposal. At this time, the funds allotted for behavioral health enhancement through the governor's biennial budget are currently unallotted, which means they are frozen. We recently held two identical stakeholder meetings specific to the enhancement project on July 20th, which were both recorded, and we distributed the slides to the enhancement stakeholder email listserv. We are also working to have these uploaded to our website. Additionally, Dr. Ward also presented an update to the Joint Subcommittee to study mental health services, which was recorded and is available at the link provided here. Concludes the frequently asked questions portion of our presentation. Thank you, everyone. I hope you have a wonderful rest of your day, and I will now turn it back over to Dr. Ward.
Thank you, April, and we're so excited to have you on our call for the first time with us as a panelist today. I am looking in our Q&A list, and I am not seeing any additional questions at this time, so we will allow for just a couple minutes. We still have 242 people on the call today, so you may be pondering potential questions. I want to remind you, you can of course reach us at the email addresses on your screen. That is, again, enhancedbh@dmas.virginia.gov or sud@dmas.virginia.gov. For questions specific to the Support Act, you can always email supportgrant@dmas.virginia.gov. There is a question from Joshua Farrow for the review of the behavioral health enhancement, the slide with the link on the video. Can that link be posted in the chat or put back up so I can copy it down? I'm going to see, Joshua, I think I have the link right here in my browser, so I'm going to come back over and post it for you. Oh, and Ashley is ahead of me. She has already posted it. It is on the Virginia Senate website. It is the first link down that says Joint Subcommittee, August 5th. And I believe that my presentation starts around the hour 30-minute mark. The first part of that presentation is by Commissioner Land from the Department of Behavioral Health.
Dr. Ward, there is a question about a participant asked us to go back to the language slide. The release date is currently not known. The Language and disability access plan is currently being reviewed by our Attorney General. And so as soon as that review is completed, we will be posting this on the Medicaid website, and we will issue a Medicaid memorandum. And what we can also do, we have your emails from attendance today. That is also something we can share through a blast email.
Thank you, Ashley. I'm looking through to see if the other questions have come in.
There is a question, Dr. Ward. Will the flexibilities be extended for behavioral health as it was for DD waiver services?
We have announced before on the call that all of the flexibilities afforded to behavioral health providers will be extended should the state of emergency be extended. So those flexibilities are afforded to us through a combination of state and federal waivers associated with the states of emergency. So we do already know that there have been extensions which we have announced, and right now, Virginia's state of emergency does not have an end date. So as soon as any of those end dates become announced or more concrete in the state of Virginia, we will communicate out about that. But for the time being, you can refer to our current memos. I see one from Jermaine Johnson. Initial paperwork for therapeutic day treatment. If new initial paperwork was completed during the summer, will they need to resign paperwork at the beginning of the school year due to services remaining virtual for the first 9 weeks? Jermaine, I don't have an answer to that today on this call. It would be helpful if you could email that to the enhanced BH mailbox. And we can get back to you on that question. I know there's numerous questions about the state of TDT, about how youth will meet medical necessity, about how providers will reach the youth based on whether school is happening or not. I know there's many, many questions, and I don't have all the answers right now, but if you email them to us, it's helpful. C1, case management is now requiring face-to-face visits in order to be reimbursed. Or other programs going to make this requirement? I'm not sure which case management you're referring to, Jessica. And we would have you please just email that question to our email box and be specific, because there are numerous types of case management services. So just be specific about which type you're inquiring about. Thank you, Jessica. She's going to email it. Again, we're also sensitive. We know that we have folks from a lot of different areas of the system that participate on the call, and we try to get as much information out there as possible across agency and across specialty, just to support the flow of communication. There's a question here from Sharon Tolliver Hardy asking, are we allowed to provide small groups for arts services? Sharon, we at the initial, to remind everyone, in our initial memo on flexibilities during COVID and limitations during COVID, we did set limits on delivering group services in person. We lifted those limits when the state went into phase 3 implementation. I believe that was August 1st. And is that correct, Ashley? Double checking my dates in my mind. Nevertheless,
I am actually going.
Is she going to pull the memo? Nonetheless, yes. It was August 1st. So we are currently allowing group face-to-face services. We're allowing reimbursement. Remember, we're the payer, not the licensor. And we are allowing payment of group face-to-face group services at this time. And that is something, of course, we continue to watch very closely. Sharon's saying it was July, which is possible.
She is correct.
She is correct. Sharon is picking up on the passage of time during COVID is, I think, at moments a fog for all of us. So yes, those are still allowed, and it's something, you know, that we are watching closely, as I'm sure you all are, as it's your staff who are really on the front lines and putting themselves in these vulnerable positions, and you're making those decisions as a provider. We too are really trying to watch the numbers and determine whether, you know, at some point in the future we would need to go back to limiting group face-to-face just for mitigation of viral spread, but there are no limitations around face-to-face services right now. So there are no limitations around group services, but we have retained all of the telehealth allowances in behavioral health that we've had since the beginning. So there is no requirement to go back to face-to-face. All of those telehealth allowances are still available to our providers. Denise Donovan has a question about the language disabilities access. Will this service be available for translating CSB client handbooks, and when? We don't know the when, and I don't know the answer to that, but if you can email our inbox, we can forward that to the right people at DMAS who are overseeing the implementation of that language disabilities access program. Let's see, any other questions at this time? As a reminder, we have kept with a bi-weekly cadence on these provider calls, which we will retain for the time being. If you recall, back in the beginning of COVID, we were doing these weekly when information was really changing very rapidly. So as we move into the fall, should we see a need to schedule one week to week, we certainly will do that. If things stabilize and the need for these calls is reduced, we will let you know and cancel them if there's no new information that week. I think we've done that one time so far. But if you have any feedback for us or kind of other questions or topic areas that you would like to see discussed on these provider calls, we're very open to that. Please let us know at the email box. We also meet regularly every other week with the behavioral health provider associations for the state and have an advisory group with them. So they also have the opportunity to advise us on topics or significant questions that their members are having in regards to our flexibilities and services or resources that folks are needing. So please continue to funnel those as well through your associations if you are members. And of course, we hold this because we know not everyone is a member of an association, and we want to have the most clear and transparent communication that we have possible for us during this state of emergency. All right, in the absence of any other questions, we wish you well. We thank you for your participation today, and we look forward to speaking with you in 2 weeks. Thanks so much.